And today we're going to pursue step 8 of the curriculum for QAPI, as defined by CMS. And today's topic is identifying your gaps and opportunities. And then the second part of this is to continue as part of our workshop here to work on the social isolation project improvement. So we can have the next slide. So one of the questions I just wanted to check on everybody, you can put in the chat box. Was there anything interesting that you learned from your structured walk rounds last week? So just put in the chat box if you what one item that really struck you from your walk rounds last week. Okay, for those that are just joining us at the moment, we're just asking for feedback in the chat box as to what you learned from your walk rounds last week.
I just have a comment about walk rounds in general. I can say that whenever I was in the facility still as an administrator, they really do make an impact because your staff is then aware that you're coming behind them to hold them accountable on certain things that you've put in place. I could say whenever I was there, I'd walk down the hall and be like, no, Kelly, we already know about that. We're going there right now. They knew what I was going to say before I even got there. So it's just a way to continue to hold your staff accountable for the systems and such that you put in place.
Yeah, very good, Kelly. Yeah, interestingly, I've never thought of it this way, but when I'm in clinic, I do walk rounds and just engage with the other doctors and nurse practitioners. In our case, I'm asking how the implementation of the age-friendly protocol is working, and so we're asking them to basically assess the geriatric 4Ms of what matters: medications, mobility, and mentation. And we're finding that we're about 50%. And so our quality improvement shows that we're about 50% of doing this reliably each time. So we want to reach 100%. So I use the walk round concept just to engage people and see if, what limitations they might have. What are the barriers to documenting those geriatric 4Ms with each clinical encounter. So we're working on the social isolation. I was just wondering if anybody had any thoughts, any barriers with their PIP. Yeah, thanks, April, for that comment about the walk rounds. It's good to see the stress level. Make sure everybody knows the policies. Yeah. Oh, wow, Cindy. Holy smokes, walk rounds has increased our vaccine rate for staff. Congratulations on that. Are you, I hope you're handing out some rewards for those, like a lollipop or something minimally.
Cindy, could you share with us, is there anything in particular you're discussing during the walk rounds? I have a lot of facilities that are still having some hesitancy. Oh, $200, yeah.
Wow, I'm coming over to get my third vaccine.
That will do it.
That's great. Yeah, some people have been using a entry into a lotto, so they will have win an iPad or something like that. If you get your vaccine, that's great. Yeah, we mentioned. I think we mentioned, and I'll just repeat if for those who may be new. That originally in January, 30% of those surveyed in the country were disinclined towards the getting the vaccine. But then with continuous education, as mentioned here, Cindy was saying educate. Probably need to add a third education in there. That it's now gone down to 18% reluctance to get the vaccine. So that's getting better. It's getting better over time. We're also finding that from our student population, believe it or not, they're reporting back that if their families had not gotten the vaccine traditionally, like if they didn't get flu vaccines and stuff like that, they themselves kind of reflect what their family attitudes are. So a lot of this is related to family background. Just kind of interesting there. All right, well that's good. Vaccine, like I say, the other things about there's a pretty cute cartoon that came up. Somebody showed a picture of Bill Gates, as we were talking about earlier. Bill Gates at his computer, and then there were all these like sort of messages from people who got the shot that were radiating, messages to from their arms to Bill Gates. So little spoof on the microchip conspiracy theory. The other thing that I wanted to mention is that the vaccines are now they're more highly recommended for in terms of the pregnancies related. It's a personal choice, but there's no harm that's been identified in the studies thus far. So we're 6 months into this, and no evidence of harm from the vaccine during pregnancy, and certainly absolutely zero evidence that vaccines cause infertility. So those are the two major gripes that most people had. And then the other question we had here is, are you using the Quality Innovations Organization or the QIN QAPI tool? So those are, I believe, were distributed. Is that correct, Sarah? Did we send those out to everybody? A copy of that?
Yep, and that's kind of what we tried to encourage them to use for the homework. However, noticing that there were some challenges or people were already using other tools. So I believe in the next email, we will be sending out 2 new tools that Michelle and her team have collected, and we will help distribute those soon.
Yeah, and you should have gotten so the QAPI tool for filling out the PIP. So there's a couple of options. We're hoping to use the QIO. Again, we're using a lot of abbreviations, but the QIO stands for Quality Innovations Organization or Network. Sometimes they call them QINs. So these are Medicare supported regional organizations to help with quality improvement. And so Michelle Lochner, our regional QI expert or QAPI expert, has developed this PIP tool that we would like to use. And the idea of everybody using that PIP tool is that we can kind of compare, apples to apples. So when we review these, everybody will recognize them and have some sort of understanding. But again, free country, you can use whatever PIP tool that suits your needs. Okay, you want to move on to the next? Yeah, so today our agenda is basically looking at the Institute for Healthcare Improvement. Again, we're using a lot of abbreviations here. IHI stands for the Institute for Healthcare Improvement. We're going to look at their curriculum, and then Michelle, Kelly, and Jean will be talking about the gaps and opportunities for the data and getting the Plan, Do, Study, Act cycles moving ahead here. Okay, so I think we're going to move into the video. Very good. So then I'm going to hand it off to Michelle after this.
Hello, and welcome to today's session on post-vaccination practices with a focus on workforce considerations. When reviewing your post-vaccination practices in your center, it's important that you review your workforce policies and procedures related to post-vaccination practices and return to work guidance. With so many changes in visitation guidance and vaccination guidance, coupled with CDC's updates on fully vaccinated individuals, oftentimes there may appear to be conflicting guidance related to our staff and post-vaccination. Our session today will walk through the current guidance in place for healthcare workers, knowing that healthcare is more stringent than non-healthcare guidance due to the vulnerable population that we serve for fully vaccinated individuals. Strategies are needed for healthcare facilities to appropriately evaluate and manage post-vaccination processes for their staff. So nursing home leaders should review and revise their policies and procedures if indicated in order to align with current CDC, state, federal, and local public health guidance. Those policies and procedures should include, but are not limited to, what you see here up on the screen. The post-vaccination signs and symptoms, the impact really of COVID-19 vaccination on staff, which is that planning for potential call-offs and the need to replace staff for 1 to 2 days post-vaccination. Core COVID-19 infection prevention strategies that must be in place regardless of vaccination status, really that include PPE, hand hygiene, signage, visitation protocols, physical distancing, and more. And then also the return to work updates respective of fully vaccinated individuals. We need to also review our overall communication strategies of policy changes, as well as the differentiation between healthcare personnel and the community at large post-vaccination practices. Update our educational materials as it relates to these new updated post-vaccination considerations, and review our surveillance processes and the tools to make sure they align with current guidance.
We will review some of the workforce considerations in this session today. Let's discuss the first of the post-vaccination practices for our staff, signs and symptoms. Systemic signs and symptoms such as fever, fatigue, headache, chills, all of those can occur following COVID-19 vaccination. Also, most systemic post-vaccination signs and symptoms we know are mild or moderate in severity, and they occur within the first 3 days of vaccination. They resolve usually within 1 to 2 days of onset and are more frequent and severe following that second dose. And remember, cough, shortness of breath, runny nose, sore throat, or loss of taste or smell are not consistent with post-vaccination symptoms, and instead may be symptoms of COVID-19 or another infection. So some of the strategies to manage those signs and symptoms is really to look at staff with post-vaccination signs and symptoms could be mistakenly considered infectious, and they could be restricted from work unnecessarily. This might also have negative consequences for staff and residents, and that is why the nursing centers must post vaccination strategies that will be needed to effectively manage post-vaccination systemic signs and symptoms in order to limit unnecessary work restrictions. Because information is currently lacking on vaccine effectiveness in the general population, the resultant reduction in disease, severity, or transmission, or even the duration of protection, vaccinated healthcare workers should continue to follow all infection control core principles of COVID-19 to protect themselves and others. Documentation of outcomes and work restrictions or return to work decisions are key. Remember, we will need to follow local, state, and CDC guidance. The CDC has published a COVID-19 toolkit for long-term care facilities called Preparing for COVID-19 Vaccination at Your Facility. This toolkit provides recommendation on vaccination scheduling. Educating staff will also be an important part of this toolkit in order to answer common questions, and it does provide as well a variety of resource links. So some considerations would be vaccinate employees right before they have a day or two off. Also, to stagger employee vaccinations so everyone on the same unit or the same department are not vaccinated on the same day, because most systemic post-vaccination signs and symptoms are mild to moderate in severity and do occur within those first 3 days. Also, educate staff on the short-term signs and symptoms, and then timely assessment of employees and test as indicated for COVID-19. We will want to work with our local public health department with any questions that we may have regarding guidance.
Additional workforce considerations in what CDC indicates that employees with fever following vaccination should stay home pending evaluation. Consider that CDC consider that COVID-19 testing. And employees, again, should be educated, really, as you see here, to report to you of the vaccination program, possible side effects, and then use the VAERS system as well. And then also we should try to assist our employees in enrolling in the vSafe application. So again, As we indicated before, work with your local public health department with any questions that you may have regarding the guidance that's available to us. And considerations to minimize really the impact of post-vaccination, really systemic signs and symptoms on staffing may include, and this is from CDC, again, like Sue indicated before, vaccinating staff preceding 1 to 2 days off or during which they are not required to be, in the facility. How we communicate with our staff and looking at what that staggering of the dosage and the considerations that may be really important for following that second dose. When we're looking at our workforce needs and looking at our scheduling, we have to consider that and communicate with our staff accordingly. Inform our staff about the potential for short-term, signs and symptoms of post-vaccination and potential options for really mitigating them if symptoms arise. And then also developing that strategy to provide timely assessment of staff with really those signs and symptoms of post-vaccination, including what those options are for COVID-19, the testing, as well as it's readily available if indicated, and offering really, there's other options we, from an operational perspective, can look at. Is there non-punitive sick leave options, paid sick leave for the day after, your COVID-19 vaccination? Again, looking at ways that we can remove barriers for reporting the symptoms, as well as making sure that we're looking at our workforce, good considerations for workforce, as well as our staffing and our scheduling needs as well.
So now let's discuss the work restrictions for the fully vaccinated healthcare provider. The recommendations are based on the current information regarding vaccines. Of course, there could be additional considerations that may restrict staff from work. The state agency or local public health department may be able to give you additional guidance on work restrictions that are applicable to the healthcare provider that is exposed to COVID-19. Fully vaccinated staff with higher risk exposures who are asymptomatic do not need to be restricted from work for 14 days following their exposure. Work restrictions for the following fully vaccinated staff categories with higher risk exposures should still be considered for staff who have underlying immunocompromising conditions, which might impact the level of protection provided by the COVID-19 vaccine. We know, however, that data on which immunocompromising conditions might affect response to the COVID-19 vaccine and the magnitude of risks are not available. Also, staff who have traveled should continue to follow the CDC's travel recommendations and requirements, including restrictions from work when recommended for any traveler. The guidance does apply to staff with potential exposure in healthcare settings to patients, visitors, or other staff that are confirmed with COVID-19 infection. Exposures can also occur after prolonged close contact with someone who is suspected of SARS-CoV-2 or COVID-19 infection when testing has not yet occurred or if the results are pending. Work restrictions described in the guidance might be applied to staff exposed to an individual if test results for the individual are not expected to return within 48 to 72 hours. Therefore, a record of staff exposed to individuals with suspected SARS-CoV-2 infections should be maintained. We want to make sure that documentation of decisions related to exposures, restriction considerations, and outcomes will be essential. The return to work guidance by CDC was updated in February of 2021. Nursing home leadership should review the updated guidance and reflect those changes in their policies and procedures. The CDC does continue to support guidance on symptom-based strategies on return to work. And remember to review guidance from your state agency and local public health department as well for further clarification. The symptom-based strategy described on the slide, as you can see, looks at the time period since symptoms first appeared, whether symptoms are improving, whether the staff member is immunocompromised, the severity of the illness, and staff who are severely immunocompromised could remain infectious for more than 20 days after symptom onset. Consultation with infectious disease specialties in this case would be recommended. Also, use of a test-based strategy for determination for these healthcare professionals return to work could be considered. So we need to remember Mild illness, moderate illness, severe illness, and critical illness they have criteria for all of those, as you can see on the slide, that is available for return to work descriptions.
Ongoing and updated education is also a key strategy for nursing home post-vaccination practices as it relates to our workforce. This education should include, but really not limited to, an update and a review of the updated workforce guidance for fully vaccinated and non-vaccinated staff. So discuss what is new, the role of healthcare staff versus community, and what that means for fully vaccinated and non-vaccinated. Differences in the need to follow current infection control guidance in the nursing home. Also discussion on the adherence to the core COVID-19 infection prevention practices. So review those practices with your staff. They do not stop, and all staff must be in adherence. We also know that those core principles include that screening, again, for all individuals who enter the facility, hand hygiene, face covering or mask, social or physical distancing, appropriate signage, cleaning and disinfection, PPE use and appropriate use, effective cohorting and resident placement, as well as testing. So our post-vaccination policies and procedures, they need to be updated, and they review that with our staff in our education, and they align with the current guidance. And it's important for us to discuss what our staff's roles and responsibilities are as it relates to post-vaccination guidance. Also included in our education, again, is the discussion about visitation, return to work, and other workforce considerations. So in summary, in our post-vaccination strategies, it's key to maintain consistent workplace practices in the face of COVID-19, and it requires a facility-wide effort and the incorporation of workforce post-vaccination strategies. These strategies, again, include policy and procedure update with the signs and symptoms of post-vaccination, impact to our staffing and what our process is, prevention strategies, our return to work updates for vaccinated and non-vaccinated individuals, communication strategies, education as we discussed, and surveillance, updating our surveillance processes. Remember, there are additional tasks, including ongoing review of CDC guidance, state and local health department instructions, and encouraging ongoing vaccinations of employees with the overall goal to mitigate the risk of transmission to the residents that we serve, as well as our staff. Post-vaccination strategies, including this key workforce consideration session that we discussed today, are key to the overall COVID-19 risk mitigation processes. Again, we want to thank you for attending this presentation on post-vaccination practices specific to workforce practices and consideration.
Okay. Anyone have any questions on that video, the post-vaccination processes? Feel free to type it in chat or unmute yourself. And in the meantime, we'll go ahead and get started here on the CWAPI at a glance review area. Last week for session 7, we looked at some types of data that you could collect when looking for areas that you would like to improve. I shared a very long list of potential data sources that you could look into. This week, we're going to explore how to decide what specific data you might want to focus on for your efforts, because we are certainly not encouraging that you be actively doing improvement efforts in that whole big long list that we sent out. It was just lots of examples and suggestions that you could take a look at and maybe identify one or two. All right, next slide. So our next step in identifying the gaps and opportunities involves reviewing those sources of information to determine if gaps or patterns exist in your systems of care that could result in quality problems, as well as exploring opportunities to make improvements. In the next few slides, I'm going to just share a couple of sources to help you identify these gaps. But the CWOPI at a Glance guidance really focuses a lot on including your residents and frontline staff in this exploration. You can, gather information about current issues and concerns during your walk rounds. Join in the resident council meetings. Those residents and caregivers may really pick up on patterns that you have not yet identified, and they may have ideas about what is at the root of the problem. And so once we start, narrowing down those gaps, we're going to be moving that into the performance improvement projects, the PIPs, that we decide to pursue as a result of our preliminary work. And those should be chosen to deal with the high risk, high volume, problem prone areas that are specifically related to quality of care or quality of life. Kelly, is there anything that you want to weigh in on in this area here?
No, I know you did mention the walk arounds, and we talked about that earlier, but there are definitely multiple sources. Care Compare is always good. And I'm not sure if Team TSI is a Texas-based system, but it basically takes your data from Care Compare, those quality measures, and compares you to regionally to some other facilities. So it helps identify some of those gaps too. And so you guys may have something similar that you use through your MDS systems, but those are always a good way to look at them too.
Okay, that's great. And I don't think we have the Team TSI. I'm not familiar with it. I certainly might have missed it. But I do know that our long-term care, our skilled facilities in North Dakota are all members of AHCA. And so they do have access to that trend tracker, which does do a lot of that, pulling stuff out of the MDS and your PBJ and all of those areas. So that could be a really good resource for identifying those gaps. So that was a great point to add in.
Yeah, and the other thing I would comment on is whenever you're looking at your quality measures or you're looking at, say, even your CASPER report to see where you fall, just make sure you're going to focus on an area that is relevant within the time. If, for instance, you trigger higher on antipsychotic use than what you should, but you have multiple people that are a bipolar diagnosis on antipsychotics, which is appropriate, but still against the CMS guidelines, then that may not be an area you want to focus your attention on because that number is really not going to change. Or if your UTIs for short term are really high, but it's because you're getting an enormous amount of admissions from this one particular hospital, then you may not want to focus on that area. I just urge you to take all those things into consideration when you're looking at focus areas. Is it something that is relevant and that you can actually achieve improvement? Or is it something that's kind of out of your control?
Great, and that leads me perfectly into the next slide, Kelly. Oh, we missed one. Let me go back one. Oh, well, maybe it got lost in the transition. Okay, so what I did have was a slide that's looking at your resident level report from CASPER. And so I'll just talk on it, even it doesn't matter if you can see it or not. Consider the MDS patterns and even data entry errors. And what you're doing right there is identifying whether this is an appropriate area to be looking at right now and for your facility. But how do you even know that? Some people, have been there a long time and do know that, but we do have a lot of turnover and a lot of new staff. And so, the easiest place to start for looking for issues is in your CASPER reports, both in those facility level reports, which we briefly discussed last week. You can compare your month to month of your own facility, see if things are getting worse in a quality of care area, but also looking at those areas that are starred. And then at your resident level reports, if you're in a CWOPI meeting and you're looking at your residents and seeing who triggers for each of the QMs. Do all these make sense? And so one of the things you need to do is make sure that you're completing your MDS correctly. Say you look at your list and you have 6 people that are triggering with antipsychotic meds. However, your consultant pharmacist is sitting right there and says, we only have 3 people in our building that are on these meds. We need to look further into this. What has gone wrong? You know, apparently there's some problem with how the MDS is being completed. And so you need to look deeper into the RAI, but it's also really important to understand what populates that quality measure. And so look for specifics in the QM user's manual. And I just have Jean, I can't see the chat right now, but I'd have Jean put the link in there for that. And so the next slide, we can move ahead, is CMS Care Compare, which Kelly mentioned as well. But it's a great place to start, you know, thinking, you know, I just pulled out one of the slides or one of the pages. This is the first page you get to when you type in your name or your neighbor's name. And this was formerly called Nursing Home Compare. It's now just, it's the same site. It's been tweaked a bit, but they have lots of other settings in there besides just nursing homes, and they put them all to one. But what comes in when you put your nursing home name, this can help you start to focus. By looking at this example here, you can see, you know, the top part is your 5-star rating. This facility ranks 2. And then you look below and you can see, I think we need to work on health inspections. That's where we've got the lowest rate. So it's a starting place for your gap analysis. Make sure that you have attended to all those issues that were cited on your last 2567. Make sure you're staying on top of that, because you know survey's going to be coming back. And especially those F tags that have been cited more than once. There's a lot more weight on those. So please make sure that we're taking a look at where we sit on Care Compare. Next slide.
Just
And
real
again,
quick,
these,
Michelle,
go
can I
ahead, Kelly.
jump in real quick? And you speak about F tags, and I would urge you all to go look at F867. That is the tag specifically about QAPI and what you need to focus on. A couple of slides back, Michelle had on there the part about finding problem-prone areas or whatever. I think you may have taken that directly from there. Anyways, but really look and read through that tag and the standards of operation, surveyors guidance, whatever. We used to call it the watermelon book. I don't know what it's called anymore, but really read through that and see what the requirements are now, because with the rules of participation, they did add in some new pieces that haven't been there for the past, before the past few years. So really familiarize yourself with it if you're unclear on what those new rules are.
Great, thanks. And again, I'm just pulling some examples from that first slide of areas to look, and I wanted to, help you find out how you get the data. And so I pulled together, there was another one on there that was related to your employee base, the patterns of caregiver turnover and absences. CMP funds were actually used to develop some toolkits that are posted on CMS websites. There's these employee toolkits, and I just get a screenshot of one of them here. They promote staff competencies and staff satisfaction, but they also provide survey tools for you to help you get the data to establish if you really do have a problem with your staff satisfaction. And if you do, it helps us find out where we're starting from. It gives us our baseline, and then we can come back and evaluate again if improvement has been made by the interventions that we implement. So just another resource that you can take a look at. There are just a few examples, but please reach out to any of us for assistance in ways to capture data, explore potential interventions, any of that. That's what our forte is. So, Jean, Kelly, and I, that's what we do. Please reach out to us for that.
And Michelle, I'll add on this particular slide that you're showing, there's a lot of templates in this slide too, and buckets of areas. So when you're doing your root cause analysis, for instance, it provides some examples of things that may be triggering, as well as examples of interventions that you could put in place. And so you can, it's really a full package toolkit. and you can use the format of it really for any project, but just kind of walk through it.
Yeah, and that's something that the QIOs are always involved in, is developing toolkits and change packages and things like that. So if there's any area that you're looking for, reach out to us for that. We've got access to so many things. It's one of my repetitive statements is don't spend a bunch of time Googling things. Ask us. We've got so much stuff that we're ready to share. So please let us know. All right, we'll go to the next slide. And we're revisiting our social isolation PIP. We have Wishick Living Center is sharing with us today. So we'll go to the next slide and welcome in Cindy and or Melissa to kind of review. I'll just mention, they've been pretty stressed there that we don't have new data at this point. And I didn't add, I just put this one screenshot in where there was the most information on their testing and data point. They had a note that they were going to plan to do the next loneliness scale again on May 17th, but we're not there yet. So, Cindy, do you want to just share what you guys have been meeting on and where we're at?
Sure. We actually had a meeting on April 30th and had discussion. Our team got together, had discussion about part of what we see since COVID has hit us is that family members and friends that used to come, gosh, some family members came every day. They lived down the street. Some came every week faithfully. They're not coming anymore. We see them very seldom. They still continue to live in town, but we feel like COVID has distanced them from the resident. And yes, the doors have been locked, but they have always had the opportunity to do either scheduled inside visits or scheduled outside in our visitation hut visits. And they're not even doing that anymore. We don't have as many social media visits as we thought we would have. It's like COVID has changed everyone to the point where have they gotten comfortable with not having to visit mom constantly? I don't know. We don't know. But part of what we should be doing and will strive to do is trying to get that back. Now, when the weather is nicer, our plan is we've ordered some furniture, nice chairs with arms that will be durable outside and sit up different areas in our grounds where they can sit comfortably in the shade and have nice visits together. They don't even have to schedule those visits. They just have to show up at the door and ask for the resident, and they can take them outside and sit outside with them for honestly as long as they want. Maybe organizing something like maybe possibly a day where we're going to ask people to please come and set up different areas, and I don't know, make it a fun day in the future when it's not snowing and raining like today, but we won't complain about the moisture. We also talked about one-to-one visits for our residents that are in their rooms. One-to-one visits have basically been done in the rooms, especially since COVID has hit. We're now asking our activity people to not do the one-to-one in the room. Get these residents out of their room into a different environment. Take them to an entirely different area of the facility. We have different corners of the facility where they could meet with them. There's pianos in different areas, that type of thing, where they could entertain the resident. So we're asking them to do that. Of course, we continue to communicate all the time with family members and residents. The residents get a newsletter weekly that's printed. And we also have all calls that go out to the family member and let them know what's happening in our building, the changes that have come upon, inviting them to come and visit the residents, trying to entice them to get them to come back. So that's what we're doing right now.
Wonderful. Thanks so much for sharing that, Cindy. I urge anybody who's got questions to just unmute and ask or shoot them into the chat. I'm
Michelle,
hoping that, oh,
I think I talk all the time. Sorry.
no, go ahead, Kelly.
Cindy, I'm just curious, are volunteers starting to come back in, and would they be able to do some of those outside visits, or even just do virtual visits, the ones that maybe, assisted with activities before or anything like that?
In our facility, our group of volunteers are basically very elderly people, and they have not come back. No.
Wondering if that was another option to start getting them involved. Awesome.
Well, and so maybe it's a matter of, the more that you get vaccinated in your building and with staff too, then letting those volunteers know that it's safe for you to come back too. But yeah, it's hard with that older population, and I'm glad they're being safe, but that's a big loss.
Right. Our residents, we only have 2 residents that are not vaccinated, so our resident numbers are good, and our staff are slowly, gradually increasing. So we're hoping by the end of the week, we'll have some better numbers for staff.
Awesome. It's such a step by step, but I'm glad to hear that those numbers are going up. And so looking at, the PDSA, the whole point of these documents is to make things easier and quicker for you to just quickly document something so you've got proof of it. When survey comes in and does ask, I don't think they're asking yet, but at some point they are going to be asking about your performance improvement projects. This gives you a very easy thing to pull out and say, this is what we're working on. It also, whether it's part of survey as a PIP, as a QAPI PIP, this is proof that you're, if they come in and say, your depression numbers have been really, really high, you can pull this out right away and say, we're already working on this, and you've got good evidence to demonstrate that. So I know that it is complicated and it's one more thing to add into your day, but there's actually things that need to be being addressed. So we're actually trying to make it easier. And so I welcome, anybody who has thoughts on these PIP forms or any of the forms, let us know if we can simplify it, make it better for you. I did share Wishick's blank form and Missouri Slopes blank form with the UND folks, and they're going to be sending those out to you guys to see if that's a better fit for your facility. So let us know what you think. And I hope we hear back from Cindy that, what they're doing next, and, how successful was moving the one-to-ones out of their rooms, and some of that outdoor stuff. So we'll keep revisiting. So thank you again, Cindy, so much. And Jean, thank you. Use your PIPs to be proactive rather than reactive. Love that. Does anybody else have anything that they would like to share, ask questions about at this point? Vanessa, I'm gonna kind of put you on the spot here. I see that you've typed in a handful of things. Is there anything you'd like to share on this or bring special attention on? I haven't even had a chance to read it. I just saw that you had added.
Let's see here. Oh, okay, here I am. I just wanted to remind facilities that as they vaccinate more staff, that if there are staff that miss work after they get their vaccination due to any type of side effects, that President Biden did put out it looks like initially I called it like a rebate or a reimbursement, more of a tax credit to small businesses to help them cover any sick pay that they have to, or leave that they have to pay for vaccinated residents, or I'm sorry, vaccinated staff. So I put the link in there as well as the information from Jenny Galbraith from the Disease Control Immunization Program. So that's what I just wanted to add in case facilities missed that. So thank you.
Awesome. That is great. Thanks, Vanessa. Okay. And I'll turn it back over to Sarah, I guess, here.
Okay, sorry about that. We just wanted to let you know, and Michelle and Kelly have kind of mentioned this throughout our presentation today, but if you would like some additional technical assistance going through this process, reach out to us, let us know, and you can probably work one-on-one with one of them.